in the bereavement department for about 7 years and been doing grief counseling for about 8 years. And most of my experience is with children and teens who are grieving, so whether it's throughout the terminal illness of their loved one or after their loved one's death. But in the past 2 or 3 years, I've also been working more with adults. So feel free if you have specific questions about either of those populations, I'll be happy to try and answer them for you all. I'm going to try to get rid of this so you can just see the PowerPoint. I'm using my husband's computer, so I'm not as familiar with it. Let's see if I...
You can just click the camera at the top. There's a mic screen. There you go. Oh, now it got rid of your screen. So you need to have the middle one needs to be green too. The screen, share your screen. Oh, did we lose Molly totally? Molly will be back. Let's just give her a second to come back in. This is one of the wonders of technology, right? Everything happens. We'll just give
Kylie broke. It's because I've been having internet problems.
Yep.
Not because I've left. Okay?
Yep, I've got it. Thanks, Eve.
Thank you.
Okay, Molly should be back any second. Hopefully. Yep, there's Molly. She's back. Hi, Molly. Oh, sound. You got to get your sound back. So click on the audio tab again.
Okay, am I back?
Yep, you're back.
Sorry, so sorry about that. Okay,
It happens.
here we go.
It happens to all of us.
There we go. All right, everyone can see my screen now?
Yep. And do you want me to turn your webcam off, Molly? Because I can.
Yes. Yes, please do. Okay.
Now we can just see your screen.
Okay. All right. So I wanted to start with just talking about some of the myths about hospice care. I think that most people have generally heard about the word hospice, but a lot of people don't know exactly what hospice means. It's kind of a funny word, might sound kind of like hospital, but there can be a lot of myths kind of floating around out there that I think do tend to scare people into knowing truly what it really is until it comes maybe at a time that you or a family member needs it. So these are just some of the common things that we hear about or that you might have heard about also. Some of them being that you're sent to hospice to die, that you're in your final hours, that, you know, the bells are tolling for you, and that really this is a pretty grim and bleak situation for you or your family member. You also may have heard that hospice hastens your death, that they're going to speed it up or somehow make it come quicker than what you want it to. It means that you're giving up hope. This is probably the biggest myth or thing that I hear about a lot from people who may not know as much about hospice, that before your goal in kind of recovering from your illness may have been to cure it or, you know, to minimize it as much as possible. And if you go on hospice, it means that you've given up those goals, and it means that you're basically just okay with your death approaching, or that your family is giving up on that sense of hope as well. There also can be some misunderstandings about the medications that can be prescribed to hospice patients. They're typically pretty high-level narcotics, and certainly people are aware that narcotics are easily addicted. You can be easily addicted to narcotics, and so they worry that if they go on hospice or a family member goes on hospice, that loved one could get addicted to narcotics. And it's just a misunderstanding, because typically it's very well controlled, the narcotics, if they use them. There are lots of different medications that can be used. There's really not a risk of addiction, especially if we're looking at, you know, the end of someone's life, which is what hospice care is typically aiming towards, caring for people in that place of their life. So really the risks are pretty minimal. They are very well controlled. And if someone was to have had a previous experience or history of narcotics addiction, then that would obviously be something that the team would take into consideration and treat very carefully. So just wanted to kind of acknowledge those. We're going to talk some more about why these things are myths or misunderstandings as I kind of go through and share more about what hospice care really is. So hospice care is built on this philosophy that we all have the right to make decisions about how we would like to die, that we have the ability to die with dignity, that we have choice over it. It's not just something that happens to us in a passive way, but that we can have active control over certain parts of our death. This isn't, I'm not saying that they support suicide or anything, assisted suicide or anything like that, but that it's meant to be something that you feel empowered about, just like any other medical care or treatment that you might undergo, that you have choice, that you have control, that you deserve to feel comfortable at the end of your life. I think most people, when they think about what they would wish for themselves at their death, would be that it could be things like being surrounded by your family, being in a comfortable place, whether that's in your home or where you're living. Some people live in an assisted living facility. For some people that might be a hospital. But that we all want to be comfortable, we want to be with our family, or most people, I shouldn't say all, and that we want to have certain choices over what that might look like or how we might feel most comfortable. For some people, that can be spiritual or religious choices as well. But generally, hospice care is referring to treatment that is given to people who are coping with a terminal illness. So an illness that, based on what most medical providers would say, is reaching a point that eventually would end this person's life. So things like cancer, heart failure, dementia, Alzheimer's, all kinds of different illnesses. And that they're at a point in their treatment that most likely they have about 6 months or less to live. And this is not an exact measurement. Nobody, even the most trained doctors and medical personnel, don't know exactly how much time someone has, but approximately about 6 months or less. Sometimes people are on hospice much longer. Some are on it much less than 6 months, especially if it's really at the end. But that's just sort of a general guideline. And to be eligible to be on hospice care, these are two of the most important criteria. And you also do need a doctor who will sign off that, yes, this is about where we are in our treatment. So it's appropriate to start pursuing hospice care. And I think, based on what I was saying earlier about the myths and misunderstandings, some of the goals are shifting for individuals who get to a place at this point in their illness. Previously, their goals may have been to cure their disease or to minimize the impact of the disease as much as possible so that they can go on with their regular life. But the goal now is shifting towards more of a meaningful quality of life rather than a quantity of life. That for some people, even while they're undergoing treatment, such as chemotherapy or radiation, it can be very difficult. It can be strenuous, it can be draining, it can make them feel bad. And for some people, if they're at a point where the chemotherapy or the radiation or whatever treatment they may be undergoing is making them feel worse and it's not really at a place that would extend their life, they decide that they want to stop those curative treatments, which is also part of hospice care, and decide to focus more on the quality of the time that they have left and to live that in a meaningful way. And certainly that's based on each individual, what that looks like. But for a lot of people, that means they want to be comfortable. They want to try to be as pain-free as possible. They want to do meaningful things like spend time with their family or be in their home, spend time with their pets. There may be last trips that they want to take or milestones to reach, like going to see their granddaughter's graduation or things like that. So the goals are shifting towards curative treatment and extending life to meaningful quality of life. As I was saying, the patient and the family are really involved in their choices about the care that they're receiving, about what kind of death they may look like. What the patient and the family are also encouraged to think about funeral planning ahead of time. This can really eliminate stress for family members after the death does happen. If any of you have experienced a loss in your life, you know that certainly right after the fact it can feel really foggy, it can feel confusing, there's a lot to do, a lot of people to call, etc. So if you're having to also think about that person's final wishes and whether they want to be buried or cremated or where they want their resting place to be or what type of songs they want sung, all of those kinds of things, it can really feel empowering to the family to know ahead of time, okay, this is what my loved one wanted and this is what we can proceed with after they've died. It just kind of takes away some of that stress. When I say choices about the death, there are certain things like you might have heard of a do not resuscitate order. Sometimes people assume that that's something, so basically that means if a person is going into cardiac arrest or that they're basically having a natural death. Oftentimes, if an ambulance is called or any medical personnel, they'll try to resuscitate the person, and sometimes this can be very traumatic, especially to someone who's already been compromised with their health or they're just in a pretty fragile place. So some people decide that they want to have what's called a do not resuscitate order, which means if I'm at that point where my body is starting to shut down, please don't use, the things to resuscitate me. Just let me kind of have a natural death. So things like their choices about the death too can be where they want it to happen. Some people want to be at their home. Some people do not want to be at their home. They want to be in a hospital or an assisted living facility or, if possible, a hospice home setting. So kind of talking about those things in advance can be really helpful. And there can also be choices about, as I was saying, sort of religious choices, that I want a priest there, I would like people to be praying for me, or I would like certain songs to be sung even as I'm still alive but I'm approaching actively dying. And any hospice care is going to be very comprehensive. There are lots of different levels of care in terms of the people who are checking on the patient, what kinds of things they're looking for or assessing for. These things can be on a physical level, so again, just what's happening with their body, what's happening with their illness. Are they comfortable? Are their medications working? Sometimes people might have things that may or may not be related to kind of their illness, such as an infection or a cold or something like that, and so they're going to be checking to make sure they have medications for those kinds of things as well in order to be comfortable. Any person who's on hospice care also has the option of having spiritual care provided to them. This is usually by a chaplain or someone specifically trained in spiritual care counseling. There can often be, as you would imagine, a lot of different thoughts and questions about that person's life. They may be reflecting on, did I live a meaningful life? Am I happy with the life I led? What's next for me? If I believe in the afterlife, what do I believe? What was I taught? All kinds of spiritual questions like that. So they have the option to have access to a spiritual care counselor or a chaplain who can help them walk through some of those things that they might be considering. Social workers and bereavement counselors too are going to be checking in on the patient and the family member in terms of their emotional needs. So how are they doing? Is there any stress? Is there any sadness? Of course you can expect those kinds of things, but is the family managing it okay? And do they need any sort of extra support? There can be counseling provided by the social worker or at times the bereavement counselor even before the patient has died. They're also going to be checking to see if the patient has certain final arrangements in place, like their wills or power of attorney, things like that, and the social worker can help kind of make those things happen. There's also the option of some social support for families and patients. Volunteers are used frequently in hospice care, trained volunteers. And the volunteers can do things like just come and sit with the patient if they happen to just want to talk with someone, or a lot of times volunteer programs will do sort of a time capsule of that person's life and recording the person talking, or photographs that are important to the patient that's shared with the family later. And at times it's hard for the family members to do those things at the time, so the volunteer is able to do that, and it can be really meaningful for the family afterwards. Or sometimes the patient or family might just need someone to run to the grocery store or pick up medication, or something that might be just more of a logistical need. And so the volunteers can help with some of those things. But most of the time it's for things like companionship of the patient or for the family member. And like I was saying, there's the emphasis on quality of life. Is this person feeling like that with the time that they have left, are they living it in ways that are meaningful to them? Um, so hopefully that kind of gives you a good understanding. The care can be provided at the patient's home. There's many times there's hospice homes that are available. This is sort of like a hospital-like setting, only it's more home-like. The patient would have the ability to have 24-hour medical care. There's always nurses and doctors and all the other staff people I was just referring to. They're all there at the hospice home, so it can be really convenient. Many times this is just a comfortable place for folks who may not want to die in their home. Or it could be if the patient has significant medical needs that being in their home is not realistic, or it's too burdensome on the family to provide all the levels of care that the patient may provide. But most of the time it's the patient's choice that they want to be somewhere home-like. The family can come stay with them there, but they have the benefit of having that accessibility, 24-hour accessibility to medical team and other staff people. And as you can imagine, most folks who are sort of reaching the end of their lives may be a little bit older, 80s, 90s, and they may or may not be in an assisted living facility. And so hospice is able to go and provide care to them there where they're already at home, they're already comfortable, and just bring in the staff who will go there to them versus them coming to us like you might do at a hospital or a doctor's office. That can be really cumbersome at the end of life. You know, you may not travel well, or it's just more convenient. It's more comfortable for the family and for the patient. As I was saying too, the support is provided not just to the patient, but also to his or her family. They're wanting to make sure that the family is okay with how things are proceeding, that the family isn't unusually stressed or sad or worried, or that there's not any lingering conflict between the family and the patient. So the support is really comprehensive in that way as well. And certainly after the patient has died, that's usually when the bereavement team steps in. So they're going to be checking in on the patient's family just to see how they are doing after the fact. Bereavement care is typically offered about 13 months after the patient has died. The reason for that is that typically there's this expectation that, of course, the first year after a patient has died can be very difficult, and even beyond a year. But we kind of provide that bereavement support to get the family through a lot of those the first holidays, the first Mother's Day, first Father's Day, birthdays. And even after that, some people are able to be treated for support too if they're still finding that they're having a difficult time with the death. And all hospice care has pretty strict regulations. Those are regulated by state and also on a federal level. But every hospice has its own sort of setup and organization. It's sort of like differences you might see in schools or certain types of doctors. So, for example, some hospices are nonprofit, some are for-profit. The specifics of the type of care they may be offering might be a little bit different. So even though you hear of hospice care as kind of a general term, the actual hospice that you might be looking at can vary based on the region or the area or many different types of reasons. So it's important to sort of look into whatever hospice you're considering to see if it feels like the right fit for you or for your loved one. I wanted to talk just a little bit about the type of grief counseling or some of the kind of the things that come up. Dr. Ellie asked me just to kind of talk about my experience with some of the grief counseling that can be offered after a patient has died. So as you can imagine too, hospice can be offered to anyone. It can be offered to children, it can be offered to teenagers, young adults, even older adults. So it's not just for patients who are older at the end of life. That can happen to any of us at any point. So there are lots of different types of losses. Loss of a spouse, loss of a child, loss of a parent, a sibling, a grandparent, even just a friend or an aunt or uncle. But some of these things that I have listed here are things that are important that to keep in mind as you're counseling anyone who's experienced an important loss in his or her life. So of course, we want to make sure that that person is safe, that they feel emotionally safe, but also that they're physically safe, that there's no risk of suicide or that someone's not coming to harm them. That's typically not a major worry in this type of counseling, but of course we're checking for that. We also want to just validate and honor their experiences. What did you go through? What was that like to have your loved one on hospice? And many people, even if their loved one is on hospice care, they've gone through months, weeks, months, even years of having a loved one with a serious illness that can be very difficult. So we even kind of explore what that was like for him or her. And also what their grief is like since this person died. We're going to be talking about how there are some similarities in grief, but it can be very personalized and individualized, and it's important to check in with your client about what those things are for him or her. There is a lot of education that is given about grief and what to expect. I think this helps people know in general what they can look for in the future. We all have certain expectations about what grief is like, and so to know a little bit more about education or maybe breaking down some of our misunderstandings about grief can help us feel more empowered and like I'm not going crazy. Of course it's normal to feel worried or confused or to feel like I can't remember things like I did before. So we often will talk about how grief affects every single part of your life. It's more than just feeling sad. Some people don't feel sad at all, but they feel all kinds of other things. And so we're kind of providing some of that education along the way so that they feel like what they're going through is normal, and most of the time that is the case. So we're also exploring and validating a whole range of feelings. I was sort of just referring to that. It's sad, we can feel angry, we can feel guilty about the care we provided or feel guilty about an argument we may have had in the past. We can feel relief, we can even feel happy and hopeful and at peace with things. So it's a whole range of spectrums even after a loved one has died. We're also checking in on what coping skills they're using and are those working for the client. We want to make sure that they do feel supported in their grief. I think at times people can feel isolated, like other people don't quite understand what they're going through, or it can be awkward to bring up, or even after some time has passed, other people tend to just sort of assume that that person is doing okay, and that can feel really lonely for the person who is grieving. So we're checking to make sure that they do feel supported, and if not, what are some options about how to make them feel more supported? Support groups or advocacy efforts, or even connecting more on an individual level. A lot of people do decide to volunteer at hospices too afterwards. I know our time is getting short too, so I'm going to kind of go quickly through some of these next few slides, and if you do have questions, feel free to ask after the role play. But we also want to explore the meaning of the loss. It's not just what's happened and how are you doing, but what does this mean for you? I recently had a client whose goldfish died, and you might think, oh, a goldfish, that's not too big of a deal. But for her, this is an 8-year-old, it was a really big deal. It was her responsibility to take care of the fish. She thought she was doing everything she should have, and it really was a surprise. The fish wasn't sick. Just one day she found it floating when she went to go give her food in the morning, and that was really upsetting to her because she felt like she had somehow caused it, or it was her responsibility, it was her pet. So really important to check in on the meaning of this loss for this person. We also kind of look at what's called secondary losses. So it's not just the loss of the loved one, but it can be also, many people in our lives are more than just a person, right? They can be someone who is always there for us, or they might affect our future. They might have been the only person who understood what it was like when I was a kid. For example, parents have that understanding of what you were like as a child, so that can be very upsetting when a parent has died. Um, some people feel a strong identity and caregiving for that loved one, and after the loved one has died, they can kind of think, well, I put so much of my life on hold to care for that person, and now I'm not sure what to do. My identity feels different. So we're kind of looking at all of these different things and many other secondary losses. These are just some examples that can kind of pile up and make the loss feel so difficult. Was talking before too about education. I just wanted to say too, most people have this understanding about Kubler-Ross and her stages of grief, that you feel denial, that you feel anger and depression and bargaining, and then you accept the loss. And most people feel like that's what grief is, and really that Kubler-Ross's work was with individuals who are dying, and certainly those are just feelings. You may or may not be experiencing them. Grief is much more than that, so that I would say is a big point of education that we often do, especially in terms of educating about grief. And certainly for clients who are younger, or really at any point along the lifespan, we're going to be looking at where is that person developmentally, what is their cognitive age, how are they understanding the world around them, and how can we tailor our approaches. So for example, for children, using play therapy or interventions with a parent to help the parent talk with the child about the death or about grief, and also just where that person is in their identity. I have a young mother client right now whose her own mother just died, and that's been very difficult for her as the client sort of in this role of expanding herself as a mom and what that means, and to not have her mom there as a source of support has been very challenging for her. So that's an important identity consideration. Some of the different interventions that we might use, education, of course, play therapy, expressive arts. We often talk with clients about how grief is more than just words. It can be very hard to describe our feelings or our thoughts or all of the changes in our lives. So we may use things like clay or paint or collage, mosaics, all kinds of things to help the clients not only express themselves but find meaning in their loss. And this can be really powerful and healing for them, and it's enjoyable. Most people, even if they don't have an artistic skill or ability, they find it enjoyable to do things that are artistic in nature. I think we all have that playfulness and artistic side, even if we had it just as a child, so it can be important for that opportunity to be provided for the client. We often sometimes will do rituals, such as lighting a candle. We might do rituals around letting go of anger or grief. It might be symbolically writing a letter or burning something, and that can be very important or powerful. And for most hospices, they're offering not just individual counseling for families after a loss or a death, but they also can connect them to other resources like support groups, workshops on grief, services of remembrance. These can be important around the holidays or in the springtime when you think about graduations and Mother's Day and Father's Day. Those can be very powerful holidays, especially right after a loss. And there also can be other types of programs too about coping with the holidays. When you think about the holidays, they're often very family driven, lots of traditions and rituals there, and that can be a source of stress for a lot of grieving folks. Something that's important in grief counseling, as with any type of counseling, is trying to avoid burnout as much as possible. As you can imagine, dealing with folks who have experienced major losses in their life, if that's the majority of the clients that you're seeing from day to day, it can become very heavy. It can be a lot. Each person's story is so unique and so devastating in its own way. And as the provider of the counseling, over time, that can be very difficult. So I just kind of listed a couple things that I found to be helpful in my own work in terms of sustainability. It's not just that day being there for my client, but over time to make sure that I am taking care of myself and making sure that I can truly be present for each of the clients that I see. So those are things like self-care. What are the things that replenish you emotionally and physically and mentally? I like to spend time with my family or do some exercise like running or yoga. I really find that to be helpful in letting go of some of the stories that I've heard throughout the day, but also making sure that I'm well rested and that I take care of my calendar, that I'm not stacking lots of child loss folks back to back, or that I might build in some breaks for myself that way as well in terms of my calendar. Always making sure you have good accessibility to supervision or supervisors, folks who have been in the field a long time or who can kind of hear what you're struggling with or hear about a case that might be especially hard for you and giving you some perspective or some different ideas of how to work with that client. Peer support can be incredibly helpful, and just saying, wow, this has been a really hard day. Can I tell you about it? And having someone kind of be there for you and validate your own experience. Knowing your own triggers, this can be really important in grief counseling. I recently, about a year ago, lost one of my grandmothers, and she was someone very important in my life, but she died around Memorial Day, which was a big family holiday on that side of the family. And as I approached that time, I really was trying to be mindful of that and my own clients who were having a hard time with the springtime or May or Memorial Day, or even, those who have experienced the loss of their grandmother. I was really on sort of more alert than usual to make sure that I wasn't letting my own grief spill over into the counseling session. So that can be really important. And supervision can be another way of helping you figure out what your triggers are. And of course, staying up to date with your trainings and education so that you can continue to learn more and more about grief and about all of the different types of losses and how each one might be a little bit different, or how to be the best counselor or provider that you can be. So of course these are all important no matter what type of counseling that you do, but I feel like especially in grief counseling. So I think that's pretty much it in terms of what I wanted to share with you about hospice. I think we wanted to try to do a brief role play and then leave some time for questions also.
All right, I'm going to try. I sent you a request, so if you'll accept that, that should start your webcam again, Molly.
Okay.
Okay. And then you can stop sharing the screen. Do you know how?
Okay. There we go.
There we go. Okay, good. All right, I'll let you start.
Okay. Hi, Lorianne. I appreciate your openness and being here today and talking more about the recent loss that you've experienced. Tell me some more about kind of what you've been through recently. What brings you to the Grief Center?
Well, I feel kind of silly for being here, because it wasn't an immediate sort of direct loss.
Sure.
But I just found out actually today, and I just had such a flood of reactions to it that a mentor of mine passed away earlier today. And when I found out that he had been diagnosed with stage 4 brain cancer and lung cancer just a couple of days ago, I remember, I got the email from a peer, and it just took my breath away. Because Dr. Locke had been such a presence at, the school that I went to. He was always there. He was always a fixture in everything that we did. And, been really hard recently to lose so many mentors.
Mhm.
You know, Dr. Jane Myers died just a few months ago, and now to lose Dr. Don Locke, it's just been really shocking at just, I guess I'm really surprised at how much impact it's had on me.
Sure. Yeah, it does sound like that surprise at hearing about the loss and about his illness, then along with others in your life who have died too, the combination is sort of surprising you and catching you off guard right now.
Mhm.
Tell me some more about how these folks were important to you.
Well, I think it's you know, I knew both of them, for example. I mean, there's been others, but I was talking to a colleague when we found out that Dr. Locke was sick on Sunday or Monday. I was talking to a colleague, and I think this is the generation that trained us. You know,
Wow.
these are the mentors, the teachers that I had when I was in my training, who I looked at. I mean, I'm not trying to, betray my faith, but at the same time, it was almost like these are the counseling gods. These are the
Sure.
people who
Mm.
created our foundation, who advocated for our licensure, who laid the foundation so that I could do what I was doing. And there's a huge loss that's felt, like there's nobody above me anymore. Like I don't
Yeah.
have that security anymore.
Yeah. Yes, it feels like not just the loss of these individuals, but the loss of a generation, and it's
Mhm.
making you feel pretty vulnerable in terms of, who do I turn to now for guidance or support or things like that.
Right.
How do you feel like this is affecting you when you think about the loss of these folks in this generation?
Well, I think that, talking to my colleague on Monday, she asked, she's like, we're losing a generation, just like you said. And she's like, well, who's next? Like, who's going to take their roles? And I took a second and I was like, it's us. We
Mm,
are.
wow. Wow. So this is changing kind of how you see yourself too and your role in your field and changing your own identity now, which can feel a little intimidating sometimes or a little strange. Like, wow,
Hmm.
I didn't really see myself in that way, but I'm starting to. Yeah,
Right.
yeah.
Yeah, now
Um,
people are coming to me, asking me the questions, and I'm like, wait a minute, I'm supposed to be asking them the questions, and they're
right.
not there.
Yes. And you said too that at first you felt a little silly that this is even impacting you. Tell me some more what you mean by that.
Well, I mean, the people who are supposed to be grieving are Don's daughter and, Jane's husband and Dr. Sweeney and it's like they're the ones who have the legitimate grief. I'm
Hmm.
just a former student, a former mentee.
Hmm.
I mean, who am I to grieve, you know, over someone who, yes, was in my life, but who I didn't have daily interactions with.
Mm-hmm. Sure. And it sounds like these folks just had so many layers of support and, so many people in their world that they affected, not just their family, but former students and colleagues and, just kind of ripples out from there. So it's understandable that even though you didn't have this day-to-day contact, that they're still important to you, that you're feeling this loss, that these folks were important in your life in terms of the professional contact too, and also your development as a counselor. So you're certainly entitled to feel the grief that you're feeling as well.
Yeah. And just feeling like, yeah, just like we're losing that generation and there's nothing I can do about it. To lose
Mm-hmm.
all that wisdom.
Mm-hmm. So it's sort of a helpless feeling
Hmm.
in addition to that sadness. Um, or a loss of control that they're dying and there's nothing that you can do about it. Say some more about that, what that feels like.
Well, it's like I saw Dr. Locke in Montreal, and of course I spoke to him and I said hi, and he asked me how things were going, but I didn't sit down with him. I was busy going here and there, and I had my kids with me, and what if I had just had, one more real conversation with him and could have learned one more thing that he had experienced in his time. I mean, he was such a
Mm-hmm.
an amazing advocate for multiculturalism and really bringing our profession to age. You know, what have we lost with
Mm-hmm.
passing?
Mm-hmm. Right. So it sounds like if you had known that you had limited time with him, or that might be the last time you were going to see him, that you would have liked to have done things a little bit differently, or had more time to talk with him, or express that gratitude for all that he did.
Yeah.
Um,
Yeah.
you're feeling.
Yeah, I mean, because I could say to his daughter, who knows, you know, your father was amazing. Like, thank you so much for sharing him with us. You know, I know
Mm.
there were days and nights that your dad wasn't home because he was taking care of some poor counselor education student that was having some crisis at NC State, you know,
Right.
and thank you for your sacrifices. But it's
Mm-hmm.
like, is that you know, it's like there's so much more that I would have wanted to thank him for that he probably didn't even know he had had an impact on me.
Yes, right. That was really important to you to be able to share with him while he was alive. So you sort of feel like it was a lost opportunity had you known that that was the last time you might have seen him, or that that was the nature of his condition at that point.
Yeah.
Yeah.
All right.
Wow.
Good stuff.
All
And I got to tell you
right.
guys, that's probably a big pressure for Molly after I having been her clinical supervisor.
Yes. 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 I had to do a lot of self-talk, like I could do this, and yes, but it's fun too. It's kind of cool to be at this point after spending so much time way back when.
Right.
Oh, yeah.
Great. Thank you, Molly. All right. I know we have some questions. So I want to make sure that I get everybody. But Molly, one of the first questions, and if any of these questions you can't answer, it's fine just to say, I don't know, but that's a great question,
Sure.
you know.
Hmm.
So
Right.
Ashley Johnson asked, what do you feel is the biggest difference between the right to die or die with dignity, such as in California, and hospice care?
The biggest difference.
Hmm. If there is one.
Um, that is a really good question. So say it for me again, hospice care versus the
The
right to die
right.
with dignity.
Yeah.
I think that there are a lot of folks out there who support that for some people, they may wish to end their life sooner than what the natural progression of things may be. And there can be a lot of different opinions about what that is like. And, especially if you can think of certain progressive illnesses like ALS, or things that are very painful, that it feels like the individual is losing a loss of their ability or their control, that in certain situations that folks may support, that I may wish to end my life in a controlled way or a dignified way. The difference then with hospice care is that suicide is not, or assisted suicide is not supported. If at any point there's any inkling of that in a patient, they're going to be assessed and screened, and certain precautions are going to be taking place. But I think because there can just be a lot of different reactions to that, and different opinions, and how to make sure that that really is where the person is, and not just maybe a temporary feeling, or something like that. So hospice care is going to be supporting the natural progression of the end of someone's life, versus having an individual who has the option or the election to do that in a controlled, medical supported way. So hopefully that, I know it's a complicated question, but hopefully that helps.
Yeah,
So,
very, very complicated. And then Venencia asked, how do you counsel someone who's afraid of death?
hmm. So just like with most counseling, you're going to say, wow, yeah, you're going to really validate that fear. I think a lot of people can relate to that. There's a lot of unknowns. There's a lot of, we don't know what's going to happen after I die, if I believe that anything will happen. And sometimes it's beyond just honoring and validating that fear, and kind of sitting with that. It's also looking at, well, what.
Oops, did we lose? Oh. We may have lost Molly. Let's see. Let me see. Oh, yeah, Molly's offline. So hopefully she'll be able to get back online here in a second. This might be Molly. Yep. Hello, Molly. Yeah, try to get back in. Yeah, just try to get back in. That's happened sometimes. All right, bye. Molly's coming right back, guys. This happens. This is, just the nature of computers. So she is going to be coming right back in to help us. Eve, if you want to, this might be a good opportunity to share a little bit, just a couple lines about your experience if you want to, since you had asked.
Okay.
Yeah.
My mother died in 1985 from ovarian cancer. We had hospice come in to help take care of her at the end of her life because I was the only one in town and I had a job and responsibility, so I could not watch her around the clock. They did an excellent job, except for at one point the medication turned up missing, and my family blamed me for that. Another time was that they didn't meet what my expectations was when my mom finally died. They would not let me watch her body be removed from the home.
Mm.
And that was a very traumatic experience for me, that they took me and forcibly walked me down the street saying, you don't want to see this, you don't want to see this.
Right.
And I did want to see that.
Yeah.
And so other than that, I thought hospice care was wonderful.
Right. And they've changed
And
some of their regulations now and their policies over the years as we've become more and more understanding of what grief is.
right.
Right.
And then when I had ovarian cancer in 2000,
Mm-hmm.
my life was very iffy, and they came in and they were a wonderful support. Physically, they monitored everything. Is anybody there?
Yeah, we're here. We're still here. I just turned on
Okay.
the webcam to improve the quality of sound.
Okay.
Yeah, I'm here too.
Okay. And they were wonderful.
Mm-hmm.
They were absolutely wonderful. In 2005, when I had my coma, the doctors were pressuring my partner to sign DNR papers because I'd been in the coma for 10 weeks, and they did not think I would come out.
Right.
And the hospice workers sat with my partner and discussed what they felt would be my wishes, and came to the conclusion that signing DNR papers was not the right thing to do.
Right.
And I'm real glad that it wasn't, because after 2 cardiac arrests and being resuscitated, about a month later, I came out of the coma.
Yep.
I'm here today.
Yeah.
And so
That's the beauty of hospice is that they help the family figure out what's best for that family, right? So it's really based on not what, society or somebody else thinks right or wrong, but what do you as a family believe is best for your family?
exactly.
Yeah.
And,
All right. Well, Molly hasn't got back in, Eve, so let me try to answer some of these other questions before we finish up, until Molly might be able to join us. Mallory, you asked about bereavement teams, and so I thought I'd take a second to tell everybody what a bereavement team is. A bereavement team is a multidisciplinary team of medical and mental health support, and sometimes spiritual support as well, who come together to serve the family's needs on a holistic level. So you might have, if you have a parent dying, for example, you might have somebody supporting the person who's dying. You'll have somebody supporting the partner. You'll have somebody supporting the children. You'll have people that are dealing with the medical care. So that every level of care, even helping the family, a lot of hospices also offer support and planning, like Molly said, the actual plans for what's going to happen once a person dies, but also identifying financial resources, ongoing grieving support services, all of that's included. So just think of it as a holistic grief team that's working and supporting the process. So let me know if that isn't helpful, Mallory. I just want to make sure that we get to these questions. Wendy's question is, how do you handle a situation if some family members are okay with at-home hospice and some family members aren't? If the patient isn't able to answer the question for themselves, then what'll happen is, the hospice will work with the family to try to determine what's the best situation for that family. And, I remember this conversation happening when my dad was in hospice, because my dad had started to really exist within a morphine state, and my sister wanted something very different for my dad than what my mom wanted. My mom was very clear on what my dad's wishes were, and it was my sister's own grief that was really getting in the way. And the hospice workers were amazing in getting and helping my sister hear what my mom was saying, and just listening to the family and helping the family work through these situations as objective as they can be on the outside, coming in and offering that support. So it looks like Molly is getting back in, so hopefully we can get her with sound again. Let's see, Molly, we got to do the sound trick again. See if you have sound. It says you're not connected, and I sent you a web. So if you'll click on the audio and see if you can get that audio working again. There's Molly. She has sound. Yay! Oh, it's gone. Here you go, Molly. Let me give you sound again. Can you get it back on? It says you're muted. Now you have camera, but no sound. Let's see if we can get, Molly's trying to get back in. I will go ahead and the other question that we have is from Jeannie.
Am I back?
Yes, you're back.
So
So
sorry. Wow, I have no idea what
that's
happened.
okay. It happens sometimes. Um,
Yeah.
Jeannie asked a question about what type of self-care, and you mentioned some of the self-care you do, but I mean, I think she's asking really specifically about secondary trauma, after
Okay.
hearing people's stories. What do you do
Right.
then? Like, how do you take care of yourself in those situations?
Um, so again, I think that the importance of supervision and peer support is what helps me the most in those cases. Really trying to recognize what's happening for me, or why am I being traumatized by hearing this person's story. Is this, also considering, is this the client that I'm able to work with, and recognizing my limits. So sometimes there are clients that, because of my own background or my own personal losses that I've been through, that just aren't appropriate for me to work with, and recognizing that, and that's okay. And so supervision really can help with that, or that peer support, and being okay with it. I think that we all like to know, we can see most people who, there are certain cases where that's not the case, or that's not always appropriate.
Hmm. And I don't know if you remember this,
I
Molly,
just,
but there was a time where
mhm.
you were presenting a case to me in supervision, and I had to ask you to stop. Do you remember?
Yes,
Yeah,
yes, I
Molly,
do.
Molly was presenting a case in supervision to me, and it was one of my high school friends who had passed away recently.
Mhm,
And so even as a supervisor, those things can happen. And Scott had died quite
mhm,
suddenly in his sleep. And as she started describing, I need some support and here's the case. I mean, it took like 3 sentences. I think
Yes.
I knew
Yeah.
exactly what
Right.
case, and you're like, Molly, I can't, this is one that's too close to home for me.
Right.
I had known Scott all of our life, and so it was very difficult, but it was the right thing for me to do as a
Right.
supervisor to say, do you have support? Do you have somebody else you can talk to about this? Because I'm not the best person for this. Molly,
Right.
what was that experience like for you, for me to have to kind of set that boundary?
Well, I think it was great modeling that, of course, we are all people and we all have our own personal lives and especially when there are very specific features about people or deaths, like you said, it was almost immediate that when I started describing, the situation or what had happened that you knew right away. And so it was helpful for me to kind of see that modeling in action, that there are just some times where we have to take care of ourselves or take care of our personal lives above professional
Right.
lives.
We have
So,
one last question, and that is from
sure.
Danielle, and it's, do counselors participate in the religious aspects of the process? What if the religion is completely different from the counselors? How do you handle that?
That's a really great question. So yes, the counselors do often participate in the sense that even though, from a professional standpoint, we're non-denominational, we're not going to impose our own beliefs or faiths on the clients that we're seeing. But faith, especially at the end of life, is so important. It's important to most folks anytime, but especially at the end of life. And so it's such a crucial element in grief counseling that you need to be open to exploring with clients, even if it is vastly different than what you believe. And a lot of it is just exploring, hearing, listening, validating that their experience. Oftentimes I have been a part of, when the patient is still alive, they want to have certain rituals performed or ceremonies, and they've invited some of the staff to be a part of that with them. And that's been really powerful for me as a clinician too, to kind of see that in action and see what that means to that person. It helps you feel like you have a better understanding of his or her life, or what the family might be experiencing afterwards too. The faith reactions can be very impacted as well. Some people feel that their faith is strengthened after the loss of a loved one, and many people find that their faith is questioned, or it's rocked a little bit, and that's scary. So I think it's a very crucial element to kind of explore with clients, even if it is different from your own, which is likely to be the case.
Yeah.
And I just wanted to go back. I know I was in the middle of answering the question about what if a patient has a fear of death, and I was saying, honoring and validating, but also trying to dig a little bit more to see, what does that person feel afraid of? Are they afraid of being in pain? Are they afraid of leaving their family behind? Are they afraid of the unknown? What is it about the death in particular are they afraid of? And seeing if there are certain things that can be done to help with that, like if they are afraid that they're going to be in pain, what things are important to them to take care of, and if not, then exploring more about what those emotions are, those reactions are. So just wanted to finish answering that question.
Yeah.
So.
Thank you so much, Molly. I knew you were a perfect person to ask and to invite. You have been wonderful. I'm so appreciative of all the knowledge that you've shared with our students. And just, again, thank you so much from the Clinical Mental Health Counseling Program. They're writing lots of thank you notes to you in the chat, so I hope you can see those. And
Yes, thank you. This has been
there's
wonderful for me as well.
Yes,
So thank you.
this is Molly's first time presenting in GoToMeeting, so this is a
Yes.
big accomplishment. So if anybody has any other questions, feel free to send those to me directly, and I'll be happy to touch base with Molly and get that information from her. Molly, thank you again. I really appreciate everything, and I will be in touch soon, okay?
Great. Thank you so much. And thanks for being patient with all my technological issues. Wow, that's pretty embarrassing,
No,
but
no,
thanks everyone for hanging in there with me.
it
So
happens to
thanks.
all of us. It's happening to me.
Okay.
They all know.
All
So.
right. Take care, everyone.
Thank
Good luck.
you. Bye, guys. You've done wonderful. Thank you. If you were on the call, make sure I have your name. Just if you're on the phone only, make sure you tell me your name. Night, guys.
I think you got my name, Lorianne, Shelley Marie.
Yes, I got you, Shelley. Thank you.
Okay, bye-bye.
Bye. Thank
Gotta get
you.
discussion 10 out.
Wendy, if you're still on, your name did pop up. I did see it.